Thank you again for joining today. We're going to go ahead and get started. I want to welcome everyone again to today's webinar. My name is Brittany Getch, and I'm a program officer on the Knowledge Success Project at Johns Hopkins Center for Communication Programs. Knowledge Success is excited to be partnering with FP2030 on this webinar. Today, we'll be exploring data, programming, and provider guidance on adolescent fertility and the family planning needs of adolescents who are in union or who are first-time parents. And as you'll see on the slide in the next few moments, we'll start with presentations on data and drivers of adolescent fertility from PRB, FHI 360, and Girls Not Brides, have a brief participant reflection, and then explore program and resource examples with Save the Children and Pathfinder International. Participants are muted throughout the duration of this conversation, but if you have questions for any of our speakers, please type them in the chat box as you follow along. My Knowledge Success and FP2030 colleagues will be moderating the chat box and will get to as many questions as time allows. This conversation will last for approximately an hour and a half, and it's being simultaneously interpreted into French, as I mentioned, and it's being recorded in both English and French. The recording will be available in the coming days. If you haven't already done so, please select your language by clicking the globe icon at the bottom of the Zoom screen. It will then take you to the English or French channel. You can then select to mute the original audio. Just a reminder about closed captioning, you may select whether or not you'd like to read captions during the webinar, and you can do so by selecting the icon with 2 C's at the bottom of the Zoom screen. To hide the captions later, you can select the same icon and select Hide Subtitle from the menu that appears. Should you have any trouble with either of these features during the webinar, please message myself or my colleague, Cosette Buckeye from Knowledge Success, and we can assist you. Now I'm pleased to introduce our moderator for today's webinar, Hima Patel. Hima Patel is the Family Planning Integration Manager at FP2030. She supports the Global Initiatives team and Secretariat in coordinating with global and country-level partners to catalyze progress on their FP2030 goals. She also engages partners with particular focus on the integration of family planning with other health and development sectors, including integration with postpartum and post-abortion family planning, HIV, maternal, newborn, and child health, nutrition, and non-communicable diseases, among other areas and sectors. She earned her Bachelor of Science in Behavioral and Community Health from the University of Maryland and her Master's of Science in Public Health from the Johns Hopkins Bloomberg School of Public Health, with a focus on international health and social and behavioral interventions. Hima is passionately committed to a future where all persons can participate as equals in society, have the freedom and ability to lead healthy lives, and make informed decisions about using contraception and having children. Welcome, Hima. Over to you.
Thank you so much, Brittany, for that lovely introduction. And thank you all for being here with us today. Adolescent and youth sexual and reproductive health, AYSRH programs, usually focus exclusively on unmarried adolescents to prevent unintended pregnancy or delay first pregnancy. Yet data shows that many adolescents who experience early pregnancy are those young women who are married or in union before the age of 18, where early pregnancy is often expected and accepted. Despite global efforts to prevent early marriage, the practice persists in many countries. And whether in marriage or not, adolescents who've given birth are often overlooked by AYSRH or maternal child health, MCH programs, falling into the gaps left over between AYSRH and MCH. Often, these young women face higher rates of closely spaced pregnancies, which are detrimental to both mother and child. The health and social risks of mothers and children from early and closely spaced pregnancies or rapid repeat pregnancies are beginning to be better understood and acknowledged. especially due to the work of the organizations represented here today. As we come together today, we'll dive into the key data on adolescent fertility, discuss some of the main drivers of early and closely spaced pregnancies, and learn more about child marriage, and examine program examples and resources to reach married adolescent girls and young first-time parents. And with that, I want to turn it over to our first presenter. We have with us today Toshiko, who is the Technical Director of Demographic Research at Population Reference Bureau, who's going to be presenting interesting data on adolescent fertility and childbearing that has come out of some of the new analysis of data for the 2021 World Population Data Sheet. Toshiko?
Thank you so much, Hima. Good morning and good afternoon, everyone. It is my great pleasure to be here with you all today. My name is Toshiko Kaneda. I'm the Technical Director of Demographic Research at PRB, Population Reference Bureau in Washington, D.C. My goal today is to describe what we know about trends in adolescent fertility to set the stage for today's webinar. And as Hima mentioned, I'll be sharing some slides drawing on data from PRB's latest 2021 World Population Data Sheet that we published under the PACE project. Next slide, please. Next slide, please. Thank you. So I'd like to start us off with this chart showing trends in age-specific fertility rates since 1950 by country income groups. Here we have the chart for the low-income countries to the left, middle income in the middle, and high income to the right. And for each group, I have 4 lines, each corresponding to a fertility rate for a given age group of women as labeled here. I know there's a lot going on here, but I'd like to draw your attention to the red lines, which correspond to adolescent fertility rates. So the number of births per 1,000 women ages 15 to 19. 2 things to notice here are that adolescent fertility rates are declining globally across countries of all 3 income groups, which is great. However, the current rate is much higher in low-income countries on the left compared to the middle and high-income countries. In low-income countries, estimated rate in 2020 was 94. So 94 births per 1,000 adolescent women, compared to 36 and 14 in middle and high-income countries. I'd also like to draw your attention to the green and blue lines above the red lines, especially in high-income countries on the right where they have crossed over. So the green line is the fertility rate for women in their 20s, and blue is for women in their 30s. So the crossover here suggests delayed childbearing. In high-income countries, women in their 30s have the highest fertility rates, followed by those in their 20s, and adolescent fertility is all the way down, as I already pointed out. In middle-income countries, you don't see any crossover, but the way in which the blue line for women in their 30s is no longer coming down may suggest the similar crossover down the road. In low-income countries, there is, however, little sign of delayed childbearing, as the rates have come down in a more parallel manner across all age groups, and adolescents still have a relatively high fertility rate. Next slide, please. So here we'll look at trends in terms of absolute number of births to adolescent girls. These lines represent the number of births to adolescents expressed in millions. The yellow line on the top is for middle-income countries, purple in the middle is for low-income, and the blue line on the bottom is for high-income countries. In my last slide, we saw that adolescent fertility rates have been declining everywhere. Here we see that absolute number of births to adolescent mothers has actually increased over time in low-income countries. In contrast, the number of births to adolescents is declining in both middle and high-income countries. This increase in low-income countries is due to the growing size of adolescent population, as these are very young countries. And these births will continue to increase for a while, though the magnitude can be reduced if the adolescent fertility rates can come down. There were estimated 19 million births to adolescent mothers in low-income countries in the 2015 to 2020 period, which is almost double what it was back in the 80s. Next slide, please. Now, moving on to another line graph with the 3 lines with the same color scheme as the last one. But this time we're looking at the share of all births to adolescent mothers since 1950. That is, what % of all births are to adolescent mothers? Here you can see that while the bottom 2 lines for middle and high-income countries have been declining in recent decades, the purple line on the top has remained at the similar rate throughout. So in low-income countries, adolescent moms accounted for 15% of all births back in 1950s, which is like 1 in 6 to 7 births. And they still account for the same share today. So compared to that 15% in low-income countries, adolescents in middle and high-income countries account for 8 and 4% of all births, respectively. So far we've looked at key trends in adolescent fertility, but what are some of the factors behind persistently high fertility among adolescents in many countries? 90% of all pregnancies among adolescents are thought to occur in marriage in less developed countries. And we all know that marriage is one of the key determinants of fertility. So let's next look at changes in marriage patterns to provide some insights for the trends in adolescent fertilities that we've been looking at. Next slide, please. So here we have a line chart showing % of women reporting that they were first married by age 20. This is not longitudinal data following the same event over time, but the graph compares the marital experience of women in different age groups. And I'm showing the data for 4 cohorts of women along the x-axis from ages 20 to 24 to 35 to 39. The countries here from DHS surveys where they had surveys since 2015 and are classified as low-income countries. So here, as you can see, the lines look rather flat across all the age groups. That is, the % of women reporting being first married by age 20 has not changed too much over time across these cohorts of women. I was expecting to see the lines to be more slanted up, with older women more likely to report early marriage than younger women, but there has been little decline in the share of women getting married as adolescents or younger in the previous 2 decades or so since these surveys. Next slide. So here is the final chart that I will be sharing. Now, another key determinant of fertility is access to family planning. And here, let's compare how married adolescents fare against older married women with respect to their unmet need family planning for spacing. These lines here show the % of married women with unmet need for the purpose of spacing birth. And data here come from PMA surveys. We're showing all the national survey results from the latest year available. And like the last graph, we have women of different age groups along the x-axis. So while there are some variations across countries here, 15 to 19-year-olds tend to have the highest or among the highest levels of unmet need for spacing compared to old married women. This demonstrates the clear need to help meet the unmet need for family planning for spacing among married adolescent girls. Much of the programming targeting adolescents focuses on the prevention of unintended pregnancies or delaying of first pregnancy. But it's also really important to help married adolescents to space their birth once they have their first child, avoid repeat pregnancies that can often be spaced really close together. And this requires a new set of programming inputs. It's of course critically important for us to continue investing in things like keeping girls in school and delaying marriage, and improving girls' and women's employment opportunities to tackle adolescent fertility. But meeting the unique family planning needs of the married adolescent girls is also critical, yet has not received as much attention. And that's why we're here today. Next slide, please. So now I'll turn it over to the other panelists who can tell us how best to address the needs of married adolescent girls. Thank you so much. And please check out our world population data sheet, as our theme this year is global fertility. And you can find, for example, things like the percent of all births to adolescents for all countries. So come check it out. Thank you so much.
Thank you so much, Toshiko. It was so interesting to hear the data come alive when you walked us through all of that. And I've been checking out the data sheets on PRB's website, and it is just fascinating to go through and see how the trends have changed over time. I was particularly struck by the point that you made that 90% of childbearing occurs in marriage. Of course, it's a little bit of a chicken and the egg argument, but you said that you'd expected that there would have been more substantial declines in the rates of early marriage, which you didn't see. And the percentage of women who are getting married before age 20 has actually remained pretty stable. And the denominator has grown significantly, so millions of girls are still getting married under the age of 18. And in some countries, there's some anecdotal evidence these days that early marriage rates are increasing actually due to COVID-19. We're also seeing that rapid repeat pregnancy among adolescents is beginning to emerge as a concern for MCH and AYSRH programs, and short birth to pregnancy intervals of less than 2 years occur at higher rates among adolescents than among older women. This may be especially true in countries that exhibit son preference or where social norms encourage rapid childbearing, like higher income countries where women may delay childbearing and then accelerate efforts to complete their family size. To speak more on this, I actually want to introduce Dr. Holly Burke, scientist in the Reproductive, Maternal, Newborn, and Child Health Division at FHI 360, who has decades of experience in the MCH world. And today she will be speaking on rapid repeat pregnancy among adolescents and teens in Uganda. Dr. Burke?
Thank you very much. Next slide, please. Thank you for having me today. Very exciting webinar, very important webinar, as our colleagues have mentioned. Today, I'd like to tell you about an analysis and paper we published on the correlates of rapid repeat pregnancy among adolescent girls and young women in Uganda. We'll drop the link to the full paper in the chat if you're interested to read more than I can cover today. Next slide, please. Short pregnancy intervals, or rapid repeat pregnancies, can contribute to maternal and child morbidity and mortality. According to an analysis of demographic and health survey data collected between 2013 and 2016 from 22 USAID priority countries, Uganda had the greatest increase in the proportion of 15 to 19-year-olds who had experienced a birth interval of less than 24 months. However, Uganda is not the only country affected. This analysis showed that only 6 of the 22 countries had made significant gains in reducing adolescent repeat pregnancy over this time period. Research has mostly focused on the factors associated with the ability of young women, regardless of parity, to prevent pregnancies. Two factors often cited are inequitable gender norms and young women's low autonomy with respect to decisions about fertility and contraceptive use. We know that once married, adolescents and young women are less able to advocate for contraceptive use, and that their misconceptions about contraception, especially concerns about negative impact on their future fertility, reduces their use of contraception. But adolescent girls and young women are a diverse group, and married adolescents who have already experienced pregnancy likely have some different needs than other groups. At the time we conducted our research, no previous research had explored factors associated with short pregnancy intervals among young women in Uganda. We conducted this research to understand the extent of the problem and to be able to guide programs to target resources with the goal of improving health outcomes. Next slide, please. Specifically, we conducted a secondary data analysis with data from 626 married or cohabiting women aged 15 to 22 years with at least one pregnancy from the 2011 Uganda Demographic and Health Survey. We used bivariate and multivariate logistic regression analyses to examine characteristics associated with rapid repeat pregnancy, defined in two ways. First, using a more common definition of a pregnancy occurring within 24 months of a prior pregnancy outcome. And then we used a more stringent definition, that is a pregnancy occurring within 12 months of a prior pregnancy outcome. Next slide, please. We found that 74% of the sample had experienced a rapid repeat pregnancy within 24 months, and 37% of the sample had experienced a rapid repeat pregnancy within 12 months. The odds of rapid repeat pregnancy, according to both definitions, increased with women's age at first marriage and the number of months between her marriage and her first birth. Rural women were also more likely than urban women to have a rapid repeat pregnancy according to both definitions. In addition, those whose partner had less than a secondary education had greater odds of experiencing a rapid repeat pregnancy at 24 months. Finally, we observed differences in repeat pregnancy at 12 months across the geographic regions in Uganda. Next slide, please. So in summary, most adolescents and young women in our sample reported experiencing a repeat pregnancy within a time frame that does not meet World Health Organization standards for healthy birth spacing. Strategies to reach young women during antenatal care and after the first birth should be prioritized. Findings from our analysis also suggest that future efforts to reduce rapid repeat pregnancy should target adolescents and young women in rural areas. Though it would be good to repeat our analyses with more recent data from Uganda and to replicate this analysis in other countries. Future research should also focus on understanding the specific reasons for short birth spacing practices and contraceptive non-use in the postpartum period, including among adolescents and young women who seek post-abortion care. Research efforts would benefit from using qualitative methodologies to understand how young women and men's fertility preferences at the onset of marriage contribute to rapid repeat pregnancy. On a larger scale, I hope that we were able to demonstrate the power of secondary data analyses to gain a deeper understanding of important subpopulations, including married adolescents who have already experienced a pregnancy. This information can be used to target and plan effective programs to encourage healthy birth spacing. We are fortunate to have demographic and health survey data to draw upon. Other fields do not have this important resource. Further, we have these data at our fingertips. Anybody can download it and analyze it for their own needs and obtain answers beyond what is shown in the summary reports. Of course, data gaps remain, but analysis of DHS data is underutilized, and it can help to answer research questions and guide program planning to maximize impact. Thank you very much.
Thank you so much, Dr. Burke, for sharing your results from the DHS secondary data analysis of rapid repeat pregnancies in Uganda. I found it so interesting that those older adolescents and teens, those girls that were aged 15 to 17 and 18 and older at first union, were more likely than girls that were 15 and younger to have had a rapid repeat pregnancy. It'll be interesting, like you said, to learn more in the future about what contributed to these differences, perhaps through some qualitative research, including the fertility and preferences of the couples, and also see these analyses in other countries. So thank you so much for the work that you've been doing. More and more research is showing that brain development among young people is not slowed and doesn't sorry, let me say that again. More and more research on brain development is showing that young people are not fully emotionally and cognitively mature until around age 25. Adult-focused maternal child health services do little to adequately support pregnant and parenting teens. Girls Not Brides is a leading advocacy group working hard to prevent early child marriage, but also to ensure that appropriate services and support are provided to adolescents once they marry. From here, I'd like to turn to Arwen Finney, Senior Data Evidence and Policy Officer at Girls Not Brides. Arwen?
Thank you very much, Hima, and thank you very much for inviting me to be here today. Girls Not Brides is very excited to be part of this conversation, which is really drawing attention to the links between adolescent fertility and child marriage. And we heard from some of the previous speakers about those links. I'm going to talk a little bit more about how child marriage and adolescent fertility are linked. And I'm also going to talk about some of the opportunities there are for addressing both of these issues together. Next slide, please. And next slide. So first of all, before going into how child marriage and adolescent pregnancy are linked, I'd like to do a quick recap of child marriage and what it is. So child marriage is any formal or informal union in which at least one of the parties is under the age of 18. But that said, mostly around the world, we see the overwhelming number of child marriage cases involve an older male and a girl under the age of 18. And child marriage varies, the prevalence varies massively between and within different regions of the world. So currently the global average is 19%. So 19% of girls globally marry before the age of 18. But you can see that there's a wide discrepancy between different regions. So in sub-Saharan Africa, 34% of girls marry before the age of 18. That figure is 28% in South Asia, where we've seen actually the biggest declines over the last 20 and 30 years. And this compares with 22% in Latin America and the Caribbean. And you can also see that if you compare the lower income countries with the higher income countries, the average prevalence among lower income countries is almost double the global average at 36%. Another key indicator for child marriage is marriage before the age of 15. So an estimated 5% of girls globally marry before the age of 15. And we know that this entails much more severe consequences for the life of the girl because of the fact that she is younger. But again, there's huge variation between different regions. For example, in West and Central Africa, it's actually around 13% of girls marrying before the age of 15 and 10% in the lowest income countries. So again, around double the global average. And in terms of scale, some of the previous speakers also alluded to this, 12 million girls marry every year. And there's projected to be 110 million girls marrying before the age of 18 between now and 2030, which means that on the basis of current trends, we're not on track to meet the SDG goal. And I think, as somebody else mentioned previously, this is partly to do with the impact of COVID, which we are seeing is beginning to potentially slow down or might even reverse the progress that has been made over the last 20 years. So how are child marriage and adolescent pregnancy linked? So the reality is that around 90% of births to adolescent mothers take place within the context of marriage. And this data is slightly old, which I think someone else previously mentioned, but on the data that we have, we know that the overwhelming majority of births to adolescent mothers take place within the context of a marriage or a union. And it's important to understand that adolescent pregnancy can be both a cause and a consequence of child marriage. So it is a bit of a chicken and an egg situation. But what that really means is that girls may become pregnant and then be pushed into marrying earlier because of that pregnancy, or they may get married and then quickly become pregnant after. And in terms of regional trends, in South Asia, pregnancy is more likely to follow marriage, whereas in Africa and Latin America and the Caribbean, both pathways are common. Next slide, please. So before going on to talk about some of the opportunities for addressing adolescent pregnancy and child marriage in tandem, I'm just going to talk through a little bit about how this fits into our approach at Girls Not Brides overall. So our approach at Girls Not Brides is very much guided by our theory of change, which you can see the image of here on the right. Our theory of change is a collective vision of the different approaches needed to create a world without child marriage and where girls can thrive. It outlines our ultimate vision, which is at the top, the impact that we're trying to make through our efforts, and the behavior, attitude, and structural changes that need to happen in order to achieve our vision of every girl being able to marry, if every girl being able to choose if and when to marry, and a world without child marriage. The theory of change was developed by the Secretariat with the input of over 150 Girls Not Brides members and partners, and it is global in nature, highlighting what a comprehensive approach should look like across different countries and regions. So there's some assumptions in our thinking that I think are useful to explain before diving into it. We focus on girls because girls are disproportionately affected by child marriage, even though it does affect boys, but to a much lesser extent. No single strategy will end child marriage because it is a cross-cutting issue. Change happens locally, but can be catalyzed at national, regional, and global levels. And very importantly, one thing I'd like to highlight is that while Girls Not Brides is committed to ending child marriage, we also are committed to supporting married girls, which is why we often refer to addressing child marriage, because that includes child marriage prevention, programming and advocacy, as well as programming and advocacy to support girls who are already married. And as we heard from previous speakers, this often means girls who are already married and who are already mothers. And so there's 4 key pillars of the strategy, which you can see highlighted in different colors. So on the left, you see greater investment in girls and their well-being. Then we have kind of community mobilization. So this involves engaging with families, parents, guardians. And then the third pillar, which is related to access to services in different sectors, including health and education and support for livelihoods. And then lastly, legal and policy change. So in terms of what we're talking about today, access to appropriate healthcare, including sexual and reproductive health, particularly contraception, maternal health care. These would come under pillar 3, access to services. And I will go on to talk a little bit about how the types of approaches that we would see being useful on the next slides, if you could go on. Next slide, please. So as I mentioned, there are two key ways in which child marriage and adolescent pregnancy are linked. So where pregnancy precedes child marriage, so in situations where pregnancy is the catalyst for child marriage, increasing unmarried girls' access to contraception and safe abortion is key. And there are a number of really important activities which child marriage advocates and programmers can do that are health related. And in this way, we can prevent child marriage, which in turn would have an effect on reducing adolescent pregnancy. So some of the key things that child marriage advocates and programmers are doing, members of our network, are things like budget advocacy for increased investment in adolescent sexual and reproductive health. So we know that many governments do not allocate sufficient resources for youth-friendly adolescent sexual and reproductive health care. And without this most fundamental investment, and without the services being available, many young people will not be able to access the contraception or the abortion or the other health services that they need in order to exercise their sexual and reproductive health and rights. Secondly, advocacy for removal of legal and policy barriers to adolescent sexual and reproductive health care. We know from around the world that even where adolescent sexual and reproductive health healthcare services exist, many policy barriers such as age restrictions, requirement for spousal consent, restrictions on unmarried adolescents accessing care can mean that adolescents are unable to actually access healthcare that exists. So it's really important that child marriage advocates work to advocate for the removal of those legal and policy barriers. And something that needs to go hand in hand with that is community-based advocacy to shift the social and gender norms, which would then also contribute to an enabling environment for policy change. Because we know that there's a huge amount of social stigma that also often acts as a barrier to adolescent girls accessing contraception and other sexual and reproductive health care. Advocacy for improved coordination between health and education sectors is key. So one of the things that we see a lot is that there's not referral mechanisms between schools and healthcare. So particularly one of the things that we need to see is the establishment of referral mechanisms between schools to service delivery points. And this can be for girls who are unmarried, so they can access contraception or post-abortion care, or if girls are pregnant, to refer them to appropriate antenatal care. Then going on to some of the other things that need to happen in school. Advocacy for CSE in schools. Many of our members are working a lot on comprehensive sexuality education, and this should ideally be linked to referral to services. We know that young people need to be able to access appropriate sexual and reproductive health care, but they also have the right and the need for complete and accurate information on sexual and reproductive health and rights, so that they're actually equipped with the skills and knowledge to make informed choices with regards to sexuality and to navigate healthy relationships. And lastly, one of the key things that our members are doing at the more national level is partnering with service providers to refer girls to sexual and reproductive health care. So community-based organizations who are already doing that community level work, engaging with parents, guardians, religious leaders on adolescent sexual and reproductive health, are well placed to refer girls to service points where they can actually access the youth-friendly sexual and reproductive health care that they need to exercise their rights. And the image that I've included here on the right is from Triggerize, who are a sexual and reproductive health care provider that community-based members of Girls Not Brides in Kenya have partnered with to increase girls' access to sexual and reproductive health care. And I think I actually saw one of our members who is part of that project on the call today. Next slide, please. So going on to child marriage programming to reduce adolescent pregnancy. So as we've heard already, child marriage often leads to adolescent pregnancy. And in these circumstances, it therefore makes logical sense that programming and advocacy to prevent child marriage would then lead to a reduction in adolescent fertility. And this applies to both efforts to preventing child marriage and efforts to support married girls. So many of the needs which married girls have are similar to the needs of unmarried girls. So many of the things from the slide before still apply. But in particular, I'd like to highlight a few other examples. So one key thing is support to return to school. So many adolescent mothers and girls who are pregnant end up leaving education. And this can be for a number of reasons. It could be because there are policies which explicitly expel them from the classroom, or it could actually be that there are no specific policies that force them to leave school, but the attitudes of their peers and of the teachers and the education system mean that they feel so unwelcome to continue with school that they will choose to leave to avoid the stigma of being an adolescent mother. Or it could simply be the case that it's too difficult for them to balance their newfound responsibilities of motherhood with continuing with their education. And so I think one thing I'd like to highlight here as well is, as Holly mentioned in her presentation on rapid repeat pregnancy, this is something that is often experienced by girls who are married. And the challenge of returning to school will be much greater for adolescent mothers who have had many children in a short space of time. It will be particularly hard for those girls to be able to resume their education. Access to comprehensive sexuality education and youth-friendly AYSRH. So similar to unmarried girls, married adolescent girls, they may continue to face barriers to accessing appropriate healthcare, even if they're married, due to provider attitudes or to policies that discriminate against them on the basis of their age. And so, as well as providing those services and removing those policy barriers, it's essential that there is advocacy done to change the social and gender norms, particularly which influence the attitudes of providers who do not want to provide family planning to young women, whether they're married or not. Maternal and child health care. So it is essential that adolescent mothers who are married are able to access services which will enable them to ensure a safe delivery and to improve the health of their children. They also need access to postpartum family planning to help them avoid those rapid repeat pregnancies, which Holly outlined in her presentation. The other two things that I quickly want to touch on, because I'm conscious I think I might be going over time, are programs that support first-time parents. So we've talked a lot about the healthcare needs of adolescent mothers, but something that is often neglected is the needs, the kind of psychosocial needs of first-time parents, because it's a very challenging time to become a parent for the first time. And especially if it's been an unintended pregnancy and it has then led to potentially unplanned marriage. This is a huge period of transition that young people have to navigate, and it can have massive implications on the dynamics within relationships and within households. So programs which support adolescent parents to navigate those changes and those challenges, and also that engage with their community and potentially their in-laws, can be really beneficial. And lastly, programs to support income generation. This can be in terms of supporting the transition from school to work, where girls were able to continue with their education after marriage or becoming a mother. But it could also be in the form of vocational training to support girls who are not able to finish school. And in both cases, this can help adolescent mothers and married adolescents to gain more financial security. So I will stop there. I apologize if I've gone over time. Just quickly, lastly to say, Girls Not Brides are just publishing a brief on supporting adolescent mothers and girls who are married. So we will share this with you along with the other resources and links to the recording. Thank you.
Hima, I'm afraid you're muted.
I am so sorry. Can you hear me now?
We can hear you now.
My apologies. Arwen, you did great on time, and I really want to thank you for highlighting those key points. I certainly learned some new facts related to child marriage and adolescent pregnancy, and I was interested to learn more about the holistic theory of change that Girls Not Brides uses. I also found it really valuable to learn that you guys are all supporting adolescents who are already married. I think that's a lot of important work that's not often done. And I appreciated how much you highlighted the work that is remaining, the work that still needs to be done regarding advocacy and referral services, including ensuring that our FP2030 commitments that are coming in acknowledge and propose strategies to reach this group. So thank you so much. I want to give a quick thank you to all of our presenters so far for bringing evidence and examples to this important discussion on married adolescent girls and young first-time parents. We are going to pause here for a few minutes to hear from you all in the audience. Brittany and Cosette will be adding some questions to the chat, and please type in your answers and thoughts. So the first few questions here, and pardon me, I'm not going to be able to say them in French. My French is non-existent. But what resonated with you from these presentations? What key points are you going to take back with you to your work? Feel free to add your thoughts to the chat. Benedict said, first-time parents, first-time mothers are a very good approach. And they had a project in Tanzania, Pathfinder, under evidence to action. Wonderful. Some are saying that friendly vocational education is important, that this is an important way to link to actors and enterprises in the value chain. Providing ample and adequate support to girls who are already married and girls who've already experienced adolescent pregnancy, yes. Early marriages affect girls' mental and physical state, yes. Developing interventions that focus and assist first-time mothers to pick up life skills and return back to school, yes, Arwen spoke on that as well. The need to address in a more focused way the psychosocial needs and to support income generation return to school of first-time parents. Family planning, or sorry, first-time parent results-based approaches. Strengthening and reviewing policies in Uganda in relation to SRHR. Referral systems between schools and hospitals, addressing child marriage across sectors to engage stakeholders and reach folks at all levels. Add parent education as well. Interesting, yes. Combat stigma that's persisting and facing adolescents. Learn about rapid repeat pregnancies in the communities and at your work. FP2030 needs to continue to encourage countries to consider married and union adolescents as a key population to reach with FP services. Thank you, Kate. Stats are depressing, Emily. How younger mothers are assisted to live a self-reliance life as a way of fighting stigma, addressing and determining factors of pregnancy. Wonderful. Community dialogue to combat local culture and other forms of VBG as well. Policy reform, yeah. A lot of these things that we've learned about today, it's going to take a lot of work at a lot of different levels to foster change. Menstrual hygiene in schools. Parent education, yeah. Parent communication, child-youth communication, it's vital. There's a lot of focus on training healthcare providers, but not enough focus on community members and dealing with young members, especially girls when they become pregnant for the first time. Young girls feel isolated and don't have the skills to reintegrate back into society. So interventions to address a more community-based approach. Family planning should be made compulsory to everyone, girls, children, and women. Mental health of young girls. Yes, I think that was mentioned by a couple of folks, but it's important to reinforce as well. Enabling reproductive health and family planning laws for youth. Engaging cultural leaders and fighting adolescent and early marriages and supporting adolescent sexual reproductive health education. These are all so wonderful. Thank you so much all for sharing. And with that, I want to move us to our moderated discussion. I'm seeing in the comments that many of you are thinking that this information is timely and relevant, but you may also be thinking about how do we actually reach married adolescent girls and young first-time parents? How do we engage them? We're going to talk through this a little bit more with some other great leaders in this work. With me today, I have Angela, who is the Maternal Adolescent Health Advisor at Save the Children. Angela is a medical doctor, public health expert, and researcher with experience in maternal, newborn, and adolescent health at policy, programmatic, clinical, and research levels in both development and humanitarian contexts in sub-Saharan Africa and South Asia. We also have Manish, who is the project director of the Youth Voices for Agency and Access Project, also known as YUVAA, at Pathfinder, India. Manish has been working within the development sector for 20 years with experience in programming, technical advice, and advocacy on adolescent and youth sexual and reproductive health, comprehensive sexuality education, family planning, gender, and HIV/AIDS. So thank you both for being here today for our moderated discussion. We will start with Angela, who worked with the government of Sierra Leone to develop a resource for reaching pregnant adolescent girls with quality comprehensive services. Angela, could you give us a brief overview of the resource and why it was developed?
Sure, thank you, Hima, and thank you for having me. So I am here representing a larger team from the Ministry of Health in Sierra Leone, UNFPA Sierra Leone, WHO, and Save the Children, some who are on this call and some who couldn't be here. So I hope I do them justice. And the joint collaboration of this large team led to the development of this guideline, which is targeted at pregnant adolescents and first-time adolescent mothers. And the reason being, Sierra Leone, like many other countries in sub-Saharan Africa, and particularly in West Africa, and given the data that we've also seen, has a high adolescent birth rate. And efforts in Sierra Leone have focused largely on adolescent pregnancy prevention, and rightly so. And so then we asked ourselves, what is happening to these girls once they get pregnant? And what's the right entry point for delaying the next pregnancy? So at what point do we target these girls once they're pregnant? Do we wait until they've completed their cycle to talk about PPFP? And then, so as we're having these discussions and looking at the data, we realized they're actually receiving the same care as older women. This is something that has also been alluded by the previous speakers. And so despite the fact that we know that the coverage, quality, and outcomes are different for older women versus adolescents, if you look at the data. So, and for across the continuum for all MNH services, right from pregnancy through to the postpartum period, somebody talked about the differences in PPFP coverage and the differences in, I think it was unmet need between the ages. So it's been seen across multiple services. Somebody alluded to this, but we also know they have unique biological, social, and developmental vulnerabilities that influence how they perceive need, how they seek, how they demand and use care, and actually how they experience care. So for instance, if you're a 15-year-old married adolescent, so you have to contend with the power dynamics of making a decision in that family household. You have to contend with the fact that there's an age dynamic involved. You are a developing adolescent, so you also have to contend with your cognitive development, your socio-emotional and identity development, which is a unique combination of issues that older women may not have, and this will influence how they're seeking care. We also found out that providers are actually often not comfortable dealing with adolescent clients. So when they come in pregnancy, they're likely to be either over-medicalized or shipped upwards, referred to more specialized centers because of fear of complications, which is not necessarily supported by the evidence. And the other thing we also know from larger maternal newborn health programming is if you target clients early on in pregnancy, then if you target them for PPFP counseling early on in pregnancy, and then if you improve the experience across the continuum of care, then you are likely to have better results when you're talking about PPFP than aiming for your first contact at the postnatal phase. So this was a combination of factors that led to the development of this guideline and what it contains. So it's a guideline targeted at health workers at different levels. And it provides guidance on the unique considerations at each stage of care, so from pregnancy through to the postpartum period. And what it does, it also brings out this unique vulnerability. So when you're dealing with an adolescent plight in pregnancy, what are the things you need to remember beyond just providing routine antenatal care? For instance, they need to take a longer time during counseling because of how they understand information at that age. And then how do you tailor care to this unique needs that they have? And the other thing that has come across the multiple speakers is that the importance of placing an emphasis on cross-sectoral care. So providers will likely provide clinical care and move on, and particularly in the postnatal period. So what we did was also include a section on the first week of and months as an adolescent mother, because of all the things that have been talked about earlier. More than any other age group, this age group requires cross-sectoral care. So linkages with mental health services, or at least a clinical acumen that looks out for things like postpartum depression, nutrition and lactation support. And this one, for these girls, it's even beyond just the routine lactation support. You have to figure out, how do you maintain exclusive breastfeeding for these girls if they will return to school or to vocational whatever vocational activities they end up doing, economic activities. So how do you maintain lactation? Issues related to responsive caregiving, which is critical for any age, any parent, but particularly for children of adolescent mothers. And then the non-health sectors, so issues around return to school, issues around, particularly for married adolescents, community structures for reconciliation. We know that sometimes if you're unmarried and you get pregnant, you may be expelled from your household. And so then there are issues around even protection and shelter, and issues around community reconciliation. So while this is not the primary responsibility of a healthcare provider, the ability to know that this is important and then provide the necessary linkages is critical for this age group.
Thank you so much, Angela. Yeah, I mean, I agree. I think taking that multi-sectoral, multi-pronged approach is crucial, as well as making sure that folks are informed at every level and feel that they are able to aid these adolescents, right? I mean, some of the barriers is a lack of confidence, a lack of knowledge, and a lack of skills. I think a follow-up question I have for you is, what are some next steps? What are some ways that some of our audience members or other folks, if they want to adapt and use this resource to their context to work with their ministries of health, what advice do you have for them?
Thank you, Hima. That's a really important question. So for starters, one thing good practice when you're developing a guideline is to shop around and see what exists and then see whether it can inform the current guideline. So when we were developing this, so we started working on this in 2019, there was none of its kind. So we could not find anything across multiple countries and contexts that was particularly targeting adolescents in pregnancy through to the postpartum period and looking at their issues and trying to adapt care to their needs. So this did not exist then. I'd be surprised if it still exists, if it now exists. So if somebody has seen a similar guideline, I'd be very interested to get in touch. So all this to say that there is a critical gap that this guideline is meeting. And so, because I'm sure there are many people on this call who are well-versed in guideline development and adaptation. So I won't go through the details of how we did this, but I would really, really encourage you to consider adapting this to your context. We know we have a rising burden of adolescent pregnancy, especially with this pandemic. We've seen the depressing statistics of not much progress, and we've now seen the proportion of births that are happening to adolescents, the proportion of births that are happening to adolescents. I hope I said that right. And so one of the things I'd like to mention is a resource that's available. So with permission from the WHO TA coordinating body, there's a TA mechanism that's housed by the WHO team for AYSRH. And you and your Ministry of Health can reach out to this TA mechanism and make the request for technical assistance to adapt this to your context. And so I say this with full permission from the coordinating body. And you can make this request through FP2030 So if there is interest to do this, we would be happy to provide the details, hopefully with the recordings. I think it would be a valuable resource to you and your countries for sure.
Thank you, Angela. And yes, I believe we will be sharing those resources with the recording after our presentation ends today. Thank you so much. I want to shift gears a little bit and turn it over to Manish. Pathfinder's been a little bit of a leader in reaching this group, starting in India and expanding to other regions such as Burkina Faso, Niger, and Tanzania and Bangladesh, where early marriage is really common. Many of those programs worked with community health workers, which can be a difficult model to sustain. And Pathfinder's back in India right now to test an approach to reach young married couples and first-time parents through social entrepreneurs and the use of digital media. Manish, could you tell us a little bit more about the purpose behind YUVAA and what makes it unique?
Thank you, Hima, and thank you all for this opportunity. So I would start with the fact to give you with a brief background about YUVAA. So YUVAA operates in India as a consortium of partnerships where we have a pool of partners with different expertise working towards a larger objective, which is basically trying to see whether social entrepreneurship can be a viable mechanism to improve demand and uptake of contraceptives among young married couples and first-time parents in the age group of 15 to 24 years. The interventions are in Bihar and Maharashtra, and the partnership has partners like Dharma Life, who is our key implementation partner, who specializes in social entrepreneurships around women empowerment, provisioning of clean energy products and health and well-being products within the communities. They have a vast experience of doing that. We have very domain-specific leaders in communication partnerships like Malin Loelintas and Gramvani, who supports us in the communication partnership. Then we have IQVIA as a capacity building partner, Bushara as a learning partner, and Reach India as the implementation program management support partner. We also had the good fortune of having Dalberg and Camber Collective as partners who have supported us during the initiation design stage as our strategic and segmentation partner. So getting back to what Hima, you mentioned about its uniqueness. So the first and the foremost uniqueness is definitely the social entrepreneurship model. So it's something trying to see that whether social entrepreneurship is a viable option to bring about a change in the contraceptive and family planning behavior among this target group within these communities. It looks into two common factors. One is that, as a part of the social entrepreneurship, it will in the longer run reduce revenue dependency on external actors, and it would automatically generate a market within the community for the target groups to adopt to such thing. And at the same time, the social entrepreneurs would also have a viable community engagement in bringing about these changes. Next uniqueness about this project is the overall social and behavior change approach that this project operates on. So we have the SBCC component curated on a segmentation approach. So the target group have been segmented into 5 different categories depending on their psychosocial intent and inclination towards contraceptive use. And the SBCC messaging is curated in terms of its content, dosage, and frequency to reach out to these target specific segments in a manner that actually it helps them move the needle from a non-user to a user, or from a user who have discontinued to again being a user. So that's another thing. And the final one I would say about the technological tools that this project has, and there are very less opportunities to really be thankful about the ongoing unusual times that we are facing. This has also presented us an opportunity to hugely build in the digital and the technological aspects of the project and amplify them as a viable tool to reach out to the communities for FP and SRHR behavior change. On top of that, as you at your beginning mentioned about the historical learning and experience that Pathfinder has, so the project also builds on the tested high impact practices of couple approach. So it's a social entrepreneur couple reaching out to a couple in the target community. It hugely tries to leverage on the importance of men involvement as a part of the overall family planning and contraceptive use decision making, and also looks at how do we work around the regressive social and gender norms so that women themselves are able to have agency and autonomy in their contraceptive decision making. So I'll pause there.
Thank you, Manish. I think it's so interesting to hear your approach with YUVAA is actually building on some of those points that Angela made earlier regarding having that multi-sectoral approach and kind of reaching folks at different levels to kind of make this systemic change. I actually have a follow-up question for you. I was looking at the resources that you shared with me that I know we will be sharing with our audience after this webinar. Could you tell me a little bit more about the Empari digital app? It seemed really interesting, and I would love to hear a little bit more about that digital side, especially in reaching adolescents and reaching young married couples. I mean, technology is kind of this new way to reach these people and maybe reach them in a way that is meaningful for them and engages them. So I'd love to hear more about this digital aspect to YUVAA's work and how that's going so far.
Sure, Hima. Thank you so much for picking that up. Yes, that's also something that gives us a lot of pride in terms of sharing those digital innovations. And thank you so much for highlighting that. Yes, Empari app, as you would know, YUVAA as a larger project also positions, if I have to share about the theory of change, so it basically positions itself on the seed model that we all know about, which looks at the multifaceted dimensions of health around supply side, demand side, and creating an enabling environment. And we are, as a part of the intervention, it's a comprehensive suite of package. It's not only where the social entrepreneurs, or as we say, YUVAA course, reaching out to the community with information, knowledge, and products on family planning and contraceptive for doorstep delivery, but at the same time, it also has involvement of private sector, private providers within the larger community and the geography that we operate in. And this Empari app is basically on-job capacity building application that has been developed. It was developed a bit earlier than YUVAA, but we have hugely amplified it from the perspective of building in the youth-friendly services component into it, the referral tracking component into it. So it basically targets service providers, both clinical and non-clinical staff within facilities to upgrade their ongoing learning skills and other things around family planning, contraception, and youth-friendly service provision. And it operates on, it's basically interactive. It definitely provides a lot of knowledge and other things, but at the same time, it's an interactive tool. So it also helps us in seeing that any member from the target group, if they are referred or they are seeking services from any of these facilities, how that service is integrated into our own MIS system. I'm also happy to share that our Pathfinder office in Bangladesh is adopting this in Bangla, and would now be, this app would be adapted within Bangladesh and will be utilized by government of Bangladesh as a tool to enhance capacities and capabilities of service providers. Currently, the application is available in 3 languages, English, Hindi, and Marathi. But it does have huge scope of adaptability and portability within different platforms. So we do look forward to larger adoption of this application.
Thank you, Manish. That actually transitions me really nicely to a question I have for both you and Angela. How do you envision scale up for you, Manish, with YUVAA, and Angela, with the guidelines that you've worked on? How do you envision scaling this up and sustaining the work that you guys are doing?
Should I start, or Angela?
Sure.
Over
Sure,
to you.
Angela, I think you're on mute.
Sure, I can go first. So the beauty about the guidelines is they were developed with and for the Ministry of Health in Sierra Leone in response to an expressed need and an unexpressed gap. And then the other thing we did during the process of development of the guidelines is we worked with the professional bodies. And during the validation process, we had groups of health workers sit and simulate using the guidelines through in practical clinical settings to see whether they would be practical, feasible, and applicable. So the fact that these were developed for the ministry helps with the ownership. And the Ministry of Sierra Leone of Health in Sierra Leone is very committed to ensuring that this scale up. So the next step for these guidelines, rather than develop a standalone training package, what we have recommended and what is going to happen is that we will develop a training module that can be integrated in existing training packages, because this guideline has information that's relevant for within the family planning training package, within the antenatal, intrapartum, postnatal. So rather than have a separate training package, you want to make sure that it's rolled out with routine training packages. And then we're also looking at mixed models of training. So it's not just classroom training, so it's also self-driven learning, because a lot of it is about considerations to adapting care. So then some of it is if you've been trained as a clinician in how to provide care in, say, how to provide antenatal care, then your refresher would be about how to adapt antenatal care to this a particular group. And so we have an active engagement with the ministry at the moment, aiming to scale them up across the country. And we're hoping to use this platform as well to generate interest to other ministries of health who may be interested, because we believe that this is a resource that could be useful across multiple countries.
Thanks, Angela. Yeah, that's really comprehensive, and it seems like an approach that will hopefully have great results as you guys continue to work with these communities. Manish, what would you like to add to this question?
Yes, I think Angela had touched on certain aspects, which is also an integral aspect of our scale-up plan. So we are trying to see the scale up of this model through a multifaceted stakeholder approach. One is definitely Dharmalife, as I mentioned about they being our primary implementation partner. So we are looking at both horizontal and vertical scale up approaches. Dharmalife, as I mentioned, that they do have a lot of reach within the communities. So how this YUVAA model can be integrated within their program portfolio is one aspect of scale up. Second aspect of scale up is to transition the different products, knowledge products, and the assets that have been created as a part of the YUVAA model to public sector. And we have seen a lot of interest from both the state governments that we are operating in right now. And as Angela mentioned about packaging, yes, we are looking at packaging of different capacity building products. We are looking at packaging of different SBCC assets that are being created, the job aids, the messages, and the whole segmented approach to reaching your target group. We are also looking at capability development as one of the component where scale up can happen hugely, and from a blended model of online and offline training, which currently operates through mobile platforms and other web platforms. We are moving to a learning management system, which will be self-paced, self-timed, having all the modules related to family planning and sexual reproductive health, entrepreneurship that are the critical driver for the capability development within the sphere of YUVAA. And last, I would say we hugely value the importance of private sector and the role that they can play in taking up such models at scale. So one of the areas again is to reach out to private sector, exhibit this model, both in terms of, and one of the things that this project would come up with, it's not only about guidance, but also about, at the same time, we will also be presenting a lot of evidence of these model being efficient and effective. So both how to do it and how it helps those changes to be translated within the communities. So that's the larger plan that we have at the moment. And we have already activated a lot of these plans. And to particularly work with the private sector, I must emphasize on the fact of having memorandum of understanding with the state governments that we are working with right now. So it helps us in easy transitioning of not only the assets, but also bringing these models at scale through their existing community health mechanisms. For example, in India, ASHA workers are there. So bringing or layering on these components within their existing program portfolios.
Wow, that's a very comprehensive approach. Thank you so much, Manish. I'm going to transition us over to the Q&A portion for the last few minutes of our webinar. And these questions are going to be for all of our presenters and panelists. The first question that we've gotten, and folks feel free to add questions directly to the chat box, and we will try to get to them based on time. The first question that we have is, how do we ensure that these efforts to address early marriage and the needs of young first-time parents are incorporating and engaging men and boys in a targeted way? So I will open this up to all of our presenters. Please feel free to unmute yourself to answer if you have a thought on how we can engage and incorporate men and boys in a targeted way. I might just call on someone. Arwen, what are your thoughts on this?
No worries, I was about to volunteer anyway. Yeah, I think obviously it's really important to engage men and boys, and in quite a few of the different interventions that we were already talking about, this is going to be critical. So if we're talking about trying to shift gender and social norms through community engagement or sensitization, that really needs to include the whole community. So engaging with the fathers of adolescent girls, engaging with the husbands of adolescent girls, engaging with guardians and religious leaders, also working with religious leaders who are very well respected in the community to support that kind of social norms engagement. I think as well, it's going to be very important to be engaging in other types of interventions with men and boys. So when it comes to healthcare provision, it's very important that any kind of values clarification trainings that are done with healthcare providers around the rights of adolescent girls and boys to access healthcare services and to use contraception and exercise their rights obviously needs to target male and female healthcare providers, as well as I would say male teachers are critical to engage around the rights of adolescent mothers and girls who are pregnant to continue with their education. So yeah, I think in many of the different interventions that we've discussed so far, it's going to be really important to be engaging with men and boys, both as kind of targets of advocacy, but also to be working with them in that kind of community dialogue, particularly where you have men of particular influence, such as religious leaders or guardians, fathers, husbands.
Thank you, Arwen. Thank you for being such a game person to answer the question that I called on you for. Thank you. I agree. I think targeting men and boys isn't something that we should overlook in this important work that we're doing, and reaching men at all sectors and all levels of influence is key. Often men are in positions of power and decision making, and engaging them is how we can have these overarching, sustaining, multi-sectoral approaches and system-wide change, policy change, advocacy, referral services, these things that we've been talking about throughout our webinar. One question that has come up that I'd like to bring up is, how have any of our presenters worked with adolescents with disabilities, and how have you been able to scale up access for their sexual reproductive health needs? So again, working with adolescents with disabilities, how have any of our presenters done that? And scaling up access for those with disabilities and their sexual reproductive health needs.
I can go again quickly because I don't have much to say, but I'm happy to fill the space, which is to say that Girls Not Brides are conscious that we haven't done much in this area, because actually the evidence base around girls with disabilities who are married is quite limited, but it's something that we are aware is important, and we want to support further research in this area and also support any programming which is supporting adolescent girls with disabilities to exercise their sexual and reproductive rights, and also to make choices about marriage. So very keen to hear if anyone has any great examples that they can share.
I'm glad Aaron went first, because I was also going to say the same thing. As we were developing this guideline, we also recognized how that it was a gap in that we could not address because of how woefully equipped our system is to handle adolescents or persons with disability. So in just thinking through adapting counseling material based on ability, access to a facility, and whether it's disability friendly. If you look at all those components of making services disability friendly, we all we could do was admit that we need to do more, but we did not have a solution.
Thank you so much, Angela and Arwen. I think those are really key points. They are a difficult population to reach, but it is also crucial, like you've both mentioned, to think about how we can best reach them. A question that has come up again, I think this might be our last question just for time, was why do you all believe it's been so difficult to get traction in this space to reach married adolescents? Why has it been so difficult to gain that foothold in this space? Might toss it over to Dr. Burke. We haven't heard from you in a while.
Yeah, sure. And related to my colleague's last statement, there hasn't been much research for people with disabilities at large, let alone adolescent and young women who have experienced pregnancy. So we have a lot of data gaps to fill. But related to your current question, why has it why haven't we done much just for at large? I think one of the big barriers, I think, is societal norms that adolescents shouldn't be having sex, and I think that kind of uncomfortability with the topic makes it hard to put it into surveys, to collect data, to program specifically around that population, because you're admitting that adolescents are having sex. And on the other side, as we heard from our colleagues from Girls Not Brides, that child marriage is also another problem, and our countries are admitting that we're not doing as well as we should be on child marriage. And I think when you have that uncomfortability, it makes it hard. And so when you're programming for maternal health, you think about you kind of lump the adolescents that are pregnant and have children in with the adult women, and that makes it sort of like you feel like you're covering them, but really you're not acknowledging their differences and that they're there, and that I think that's the uncomfortability. But I'd love to hear from others what they think.
Do we have a final comment on this last question of ours?
Yeah, Hima, this is Manisha. I can add from a married adolescent and perspective. So there are, as Dr. Burke said about the social norms, yes, So when adolescent is getting married at an early age, the primary motive behind that marriage is to have children, and that's the critical driver in most of the places that we are operating in, at least in India and South Asia. Then the next social norm or the gender norm that hugely affects them is proof of fertility. So the moment one gets married, both the girl and the boy will have a huge pressure from the household and from the community to prove fertility, and that eventually means having children. And last one, we have also seen in areas where there are a huge level of poverty and people are migrating for work. So most of the time, the families prefer that the boy should be married at an early age, which obviously would mean that the girl is younger than the boy. And before they move out to other places for job opportunities or livelihoods opportunities, they would like to have a complete family, which basically would mean again childbirth. So all these are complex areas, and at the same time, the lack of access to information, knowledge, and products and services are definitely amplified to the next level.
Thank you, Manish. Yes, I agree. I mean, acknowledging that this is a problem is already the first step towards making change towards it, like Dr. Brooks mentioned, and knowing that there's a lot of societal pressure, a lot of social norms that vary across cultural and country contexts that need to be addressed to even have more effective change, long-term change is something that is difficult to do, but it's such important work. So thank you all for being here today. I just want to take a quick second at the end of our webinar here to thank everybody for joining us, our audience members, our presenters, our panelists. It was such a wonderful opportunity for me to learn more about the work that's being done in this important space, and moving for me to learn how much time, effort, and energy is being put by our partners here and the folks that are here with us today towards this topic area. I'm going to actually turn it over to Brittany, and I want to give a quick thank you to Brittany and Cosette at Knowledge SUCCESS and Kate and Emily at FP2030 for coordinating this event. So over to you, Brittany. Thank you all for being here.
Thanks, Hima. And thanks to all of our speakers and to all of you for the wonderful and engaged and thoughtful discussion that was happening in the chat. So many great comments on meeting the needs of adolescents who are in union or who are first-time parents and adolescent fertility. And I would encourage all of you to follow FP2030 and Knowledge SUCCESS, as well as all the organizations that joined us today at the handles that you see on the screen to stay updated on resources, activities, and upcoming events. As I mentioned at the beginning of the webinar, we'll be posting and sending out a recording in both English and French, and we'll be sure to share the resources that were shared in the chat as well in that follow-up email. Thank you all again so much for joining us, and we hope you have a great rest of your day, evening, and night. Thank you.